السلام عليكم. صباح الخير عندكم. طيب we'll go ahead and start. طيب ده حيكون الليكشر الثاني، حيكون عن الكولوريكتال كانسر. Okay, so just the resource for all these slides and material is from up to date and from the NCCN. Right. Colorectal cancer is considered the third most common cancer in males after prostate and lungs, and the second in females after breast cancer. It is the second cause of cancer death. The incidence and mortality rates vary according to the region and countries. The incidence of colorectal cancer in general is rising in young patients under the age of 50, predominantly left-sided and rectal cancer. More than 86% of those patients are symptomatic, present with advanced stage disease, and of course, the outcome is poor. Presentation, the most common presentation is for advanced stage diseases is either change in bowel habits, that's the most common, which lead to presentation to doctors or for colonoscopy, hematochezia, this is the left side colon cancer, rectosigmoid, rectal pain, abdominal pain is not common, iron deficiency anemia, right side colon cancer, and of course, in countries where screening colonoscopies is the standard of care, then that's how most of colon cancer are discovered. Emergency presentation in case of bowel obstruction, perforation, bleeding. Unusual presentation in case of locally advanced disease, which lead to invasion to the surrounding, the neighborhood, which lead to fistula formation. Also, in case of intra-abdominal or retroperitoneal invasion that lead to abscesses, patient may present with fever of unknown origin. Of interest is actually infective endocarditis, especially Streptococcus bovis, which is considered a silent sign of colon cancer, to the point that some authorities actually recommend colonoscopy for patients with Strep bovis infection or endocarditis. Risk factors. There are 3 risk factors. There are some risk factors that influence screening, risk factor not influence screening, and risk factor may influence screening for colorectal cancer. So we'll start with the factor that influence screening, which is the common is the genetic risk factor, which is Lynch syndrome, hereditary non-polyposis colorectal cancer, HNPCC, or familial adenomatous polyposis, FAP. Personal or family history of sporadic colorectal cancer or adenomatous polyps, thus we should modify the screening. Or patients with inflammatory bowel disease, ulcerative colitis, and Crohn's disease. Patient who receive radiation to the pelvis or the abdomen, and patient with cystic fibrosis. Those are the risk factors that not influence the screening, which is the may influence the screening, like the race, African American more than whites, gender, males more than females, and those are the risk factors not influencing screening are listed here. So we are going to go over the factor that influences screening, because that's modified the screening program, which is Lynch syndrome, 25 to 75% on the lifetime risk for colorectal cancer for patients with Lynch syndrome, very high. But fortunately, it's only 5% or less. Lynch syndrome is an autosomal dominant disease. These are the genes that are mutated, lead to Lynch syndrome. Lynch syndrome is characterized by MSI high or deficient MMR, MSI microsatellite instability, or deficient MMR. For those patients, if they are, we run another test, which is a BRAF mutation, which if it is positive or mutated, it suggests it is a sporadic rather than Lynch syndrome. So not all MSI high or deficient MMR are Lynch syndrome, but that's a majority, but there's 15% of sporadic cases are actually MSI high or deficient MMR. The NCCN guidelines, they recommend or at least to consider germline evaluation for all individuals with colorectal cancer at age of 50 or less at time of diagnosis. So younger patients with colorectal cancer, all of them now recommended or at least considered doing the germline mutation to rule out Lynch syndrome. FAB, it's an autonomous autosomal dominant risk factor carried by the gene, which is the APC gene. 50% of patients of FAB will develop adenomas by age of 15 and 95% by age of 35. And 90%, there's a 90% risk of colorectal cancer by age of 45, very high. So what kind of screening? Screening is typically colonoscopy, but we started the screening for general population, for average patient at age of 50, but patient at high risk, we modify that. So high risk means predisposing inherited syndrome, Lynch syndrome, and FAB, family history of colorectal cancer, inherited syndromes, inflammatory bowel disease, and abdominal radiation. In the United States, the United States Preventive Service Task Force and American Cancer Society, they recommend to do the colonoscopy at a younger age less than 50. Now it is age of 45. So the screening, the standard of care, and the best screening is colonoscopy, of course. For average patient, not high risk, the Lynch, FAB, radiation, family history of colorectal cancer, the average is age of 50 to 75, but we said now it's dropped to 45. For patient after age of 76 to 85, individualized case by case. If colonoscopy is normal, we repeat colonoscopy in 10 years. The colonoscopy diagnosis of colon cancer at a rate of 2 to 6%. If the colonoscopy shows adenomas, especially serrated polyps, we should do tattooing. The endoscopist, surgeon, or internist, or GI, if they find adenomas, or especially serrated polyps, they make tattoos so you can go back if need to resect more or after reviewing the pathology. Here are some criteria for the findings of the polyps. Just an example here. Small polyps, 1 to 2 polyps, less than 1 centimeter, repeat colonoscopy in 7 to 10 years, and so forth. But for advanced adenomas, means tubular adenoma more than 10 millimeter, more than 1 centimeter, with a high-grade dysplasia, tubular villus or villus adenomas, or 5 to 10 adenomas, even less than 10 millimeter, repeat colonoscopy in 3 years. But for more than 10 adenomas or polyps on one exam, colonoscopy should be repeated in 1 year. And another thing, that's more than 10 polyps on a single exam, or cumulative more than 10 polyps in lifetime, we should evaluate those patients for colorectal cancer syndrome, Lynch or FAB, by doing germline testing. For a polyp more than 2 centimeters, 20 millimeters, removed in piecemeal, we should repeat colonoscopy in 6 months. For high-risk patient, the Lynch syndrome, HNPCC, those patients will do colonoscopy at age of 20 to 25 or 2 to 3 years prior to earliest age of colorectal cancer in family. Colon cancer or unresectable polyps, the recommendation is to do total colectomy with ileorectal anastomosis. Rectal cancer, we do proctocolectomy. If a patient has high risk and had surgery with the hemicolectomy, he still has rest of the colon or the rectum, we should do annual endoscopy. And we do other screening for endometrial cancer for women, ovarian cancer for women, EGD and gastric biopsy, UA for renal cell cancer, because those patients are at high risk for other cancers. Patients with FAB, we do annual SIG or colonoscopy at age of 10 to 12 for teenagers. Colorectal cancer, if diagnosed, then the treatment is total colectomy. And we do EGD at onset of colonic polyps at age of 20 to 25. High-risk patients, also family history of colorectal cancer or advanced polyps in a first-degree relative, more than one relative, first-degree relative at any age. We do the screening at age of 40 or 10 years before first-degree relative diagnosis with cancer. And then we repeat colonoscopy every 5 years. Juvenile polyposis syndromes, so I'm just going to go over those. Cowden syndrome, PTN hematomas, we do colonoscopy at age of 35. MAB, we do colonoscopy at age of 20. Those are rare, but we mainly focus on Lynch and FAB. So other screening other than colonoscopy, we could do fecal immunochemical testing for ocal blood. If that's available in your lab, you could do that in a single sample. But if that's not available, only you have focal ocal blood test, you need to do 3 at a different bowel movements. So we do the test for 3 sets, and it could be done annually. The Cologuard now is interest for some patients who they do not like to have colonoscopy. It's an alternative. It's not the best, but if it is positive, of course, you need colonoscopy because Cologuard does not give you the luxury of doing biopsy. So if you do Cologuard, which is a multi-targeted stool DNA, it is a very messy procedure. You have to collect the stool, send it back to the lab. It could be done every 3 years. Another opportunity or another way to do screening is computed tomography coronography, but I have not seen that being done anymore, but just in the textbook. Sigmoidoscopy, 5 to 10 years. You can combine sigmoidoscopy with the stool ocal blood. Capsule endoscopy, colonoscopy or capsule endoscopy. The pill cam, patient to swallow the camera, take a picture, no biopsy, of course, for screening. If it's positive, you need to do colonoscopy. And now researchers, they're showing a lot of interest in doing circulating tumor DNA. Okay. Diagnosis. Of course, depends on the symptom and signs. Screening colonoscopy is way for the diagnosis. If you find polyp, a mass, take a biopsy. It's typically adenocarcinoma, fecal ocal blood test positive. This is the way for diagnosis. Just remember, CEA, which is a tumor marker for colon cancer, is not a diagnostic test. So we recommend not to do CEA for patients without colon cancer. CEA is only after diagnosis of colon cancer. So it's not a diagnostic test. Histopathology, typically carcinoma, adenocarcinoma more than 90%. This is just for the pathology. Typically CK20 positive, CDX positive, CK7 negative. We need to evaluate for the grade, low grade, high grade, intermediate grade, lymphovascular invasion. The most important, you need to remember, all colon cancer, we should run for mismatch repair, which is the MMR, and MMR run by immunohistochemistry, very simple test, but MSI by PCR, so kind of the more or a fancy test, the MSI, but MMR is sufficient. Either one is okay. MMR is more easy. If you do MSI, MSI, if it comes back high or the MMR come back deficient, that is characteristic for Lynch syndrome. However, not all patients with MMR deficient or MSI high, they have Lynch. So there are 15% of cases that they are MSI high, MMR deficient. They are not Lynch, so we run a test called BRAF. If mutated, likely it is a sporadic cancer, not hereditary, so you do not have to do germline testing. patient, why we do the test, why we do the MSI and MMR test, why? So we do it because it carries a better prognosis. Also, for another reason, patients with MMR deficient or MSI high, they do not respond well to the fluoropyrimidine drugs, which is very common. This is the backbone for the colon cancer, 5-FU and capecitabine or Xeloda. So if they are, do not use them by themselves because they do not benefit from it. So these are the rare type of the cancer in the pathology. So if we do biopsy or polypectomy and you find a malignant polyp, also again you run the MMR, MSI, and the polyp means T1. We'll go over that a little bit later. If you have a polyp, if you find a polyp on the colonoscopy, the polyp should be removed completely in one piece. That's the key. So it should be removed in one, not fragmented. If it is a sessile or with favorable features, you could remove it and observe, but there is an option for colectomy or resection if it is sessile. If it's pedunculated, the favorable features, remove the polyp with a negative margin, and nothing else needs to be done. If the polyp for some reason removed in fragments, then that's a dilemma. Then you have to do more testing, and you may need to do surgery. Of course, if the biopsy or the polypectomy revealed a tumor that is a T2, we'll go a little bit later what T2 means. That means it is an invasive cancer, and that is quote unquote we call colorectal cancer, and need to do more. So the workup, of course, we review the pathology. We run MSI, as we said, for MSI high or the D dimer, and if positive, we run BRAF. We need blood counts. We need liver function test, CAA, CT scan for metastasis, for all rectal cancer, all of them. They should have an MRI of the pelvis or endoscopic ultrasound. EUS or MRI, that is standard of care for all rectal cancer. CT scan by itself is not enough. If it is metastatic disease, then all specimens should be run for biomarkers because that's helpful for treatment. We'll go over that later on. KRAS, NRAS, BRAF, HER2, MMR, MSI, all that should be run on the specimen to help you for the treatment. PET scan for if metastatic, and may consider liver MRI case by case. Staging. This is before we go for the staging. You need to remember those couple of facts to help you with the decided stage. Any smooth metastatic nodules in a pericolonic or perirectal fat is considered a lymph node, even if it's not a lymph node. So any nodule that is in the smooth in the pericolonic or perirectal fat, that is considered a lymph node. On the other hand, any irregular metastatic nodule or nodules in peritumoral fat, so next to the tumor, is considered vascular invasion, not a lymph node. So for staging, to go by the book, you need at least 12 lymph nodes negative to call it stage 2. Anything less than 12 is the poor staging. Yeah. For the staging, just to make it simple, on this cartoon or drawing, see remember colon cancer, the stage does not depend on the size of the tumor. By the way, you hear me well, or I didn't ask? Hello? You guys hear me?
Yes, go ahead.
We're good? So okay. So for the stage, it is not about how big the tumor, like lung cancer, breast cancer, usually staging. We talk about how big the tumor. For the colon and rectal cancer, we do not rely on how big the tumor. We rely on how deep is the tumor in the wall of the colon. So it is about the depth of invasion rather than the tumor size. So for a tumor that invades through the lamina propria, that is a TIS, tumor in situ or in situ, that's a stage 0. If it goes deeper down in the submucosa, that is a T1, or what we call malignant polyp. That's a malignant polyp. That's not a tumor. That's not a cancer yet. Not like invasive cancer yet, invading deep in the muscle. So if it reaches the muscle, the muscularis, that is a T2, and that is when we call, that is from this stage onward, then we talk about more invasive cancer. Then if the cancer goes deeper in the muscle and go to the outside, approaches the serosa and beyond, that is a T3. And of course, if a cancer reaches to a lymph node, that is a stage 3. And of course, if it metastasizes to lung, liver, anywhere, that's stage 4. This is just a picture of from a colonoscopy. I took this from Dr. Bushra. He gave me this. This is a huge tumor he found during colonoscopy. This is just a staging in words. This is just a drawing for staging. So let's just go to the management. So management of colon cancer, basically surgery is the standard of care for colon cancer. And those are the surgical procedures. Surgery, it could be for colon cancer, it could be hemicolectomy or total colectomy, depends. Total colectomy for hereditary cancer like Lynch or FAB, hemicolectomy for non-hereditary. Rectal cancer, the standard care procedure is total mesorectal excision, because the rectum, remember, is not covered by the peritoneum. So we do total mesorectal excision, TME, and the options are either APR, abdominal peritoneal resection, or lower anterior resection. We can do even ultra LAR, diverting colostomy, another procedure, situ reduction surgery, CRS with HEPIC, heated intraperitoneal chemotherapy. That is for peritoneal metastasis. This is another procedure. This is just a name of this surgical procedure, or even liver transplant now in a clinical trial for metastatic colorectal cancer to the liver only. Systemic therapy, chemotherapy, biologic agents, targeted therapy, we'll go over that later, chemo and radiation, especially for rectal cancer, not for colon cancer. Radiation by itself could be used. So management, I'm going to divide it to non-metastatic and metastatic. So what about we start with the non-metastatic. So what are the options? So start with the colon cancer. I'm going to divide them to colon cancer and rectal cancer because the treatment is different. For colon cancer, surgery, again, if the patient presents with resectable, either obstructive or not obstructive, but resectable, then the surgical treatment is colectomy with in-block lymph node dissection. If unresectable or obstructing, then you cannot do surgery, of course, but at least you could resect the tumor just to relieve the obstruction and make a diversion colostomy. Or sometimes you cannot even do that, just a colostomy, simple procedure just to relieve the obstruction, or stenting. For bulky nodal disease, clinical T4, that means invading the neighborhood, attached to the neighborhood, to the adjacent structures, then you may consider neoadjuvant chemotherapy, though this is not the standard, but sometimes case by case, you could do that to make it possible, to make the tumor resectable, just to shrink it and do the surgery later on. And typically it's colectomy with in-block lymph node dissection. If totally unresectable or medically inoperable, the patient not in a shape to go through surgery, then you can use chemotherapy with or without radiation, reevaluate for conversion to resection later on. What about the adjuvant chemotherapy? So we give adjuvant chemotherapy. So for stage 1, remember that is only to the submucosa. That is only observation surgery and nothing else. For stage 2, going to the muscularis, not to the serosa. That is actually to the serosa. Up to the serosa, that is stage 2. For those also observation, for most of the cases, in selective cases, we offer adjuvant chemotherapy. We'll go over that later. So it's stage, this is actually here. Stage 2 with high risk features, we may offer them adjuvant chemotherapy. So observation only for if there is no high risk feature, is this for stage 2, no high risk feature. Patient with, again, we mentioned this, a patient with MSI high, microsatellite instability, or deficient MMR, this it is considered favorable prognosis. Remember, we said those are the patients, they may have Lynch syndrome, especially if they have MMR, BRAF negative. So, but anyway, I mentioned this here because those patients have favorable prognosis, good prognosis, and they do not benefit from fluorobarimetine chemotherapy, which is 5-FU and or Xeloda or capecitabine. So they don't benefit from it. So if it's stage 2, don't offer them because there's no help, and there is no oxaliplatin for those patients. It's not recommended. For a patient with a stage 3, went down all the way to the serosa, not to the lymph nodes, stage 2A, if they are MMR proficient, not deficient, and no high-risk features, and they want to do whatever available, then, and they're pushing for chemotherapy because they want to do everything not to have cancer again, you may offer them 12 gene recurrence score, which is Oncotype DX. Nowadays available is the circulating tumor DNA testing is becoming of a lot of interest for the risk stratification and even for screening. So circulating DNA is something that we do nowadays for patients with to stratify them to see their risk for recurrence. Radiation is given in colon cancer. Radiation is typically not part of the treatment, except for T4 invasion. It has to be to a fixed organ, not to a mobile organ. So it has to be a fixed organ. Then you may offer radiation. Otherwise, radiation is not part of treatment for colon cancer. It is for rectal cancer, as you know. Adjuvant chemotherapy. We offer adjuvant chemotherapy for stage 2 cancer. This is the patient that we offer them is stage 2 node negative, of course. We offer them chemotherapy if they have one of these. T4, present with perforation, obstruction, poorly differentiated cancer, lymphovascular invasion, or perineural invasion. Patient with circulating tumor DNA that are at high risk for recurrence, we offer them chemotherapy. Or patient who had surgery with removal. Remember, we said we need more than 12 lymph nodes. The surgeon remove less than 12 lymph nodes, we consider that suboptimal, so we offer those patients adjuvant chemotherapy. Patient with the, if we give chemotherapy, we use 5-FU and or Folfox for 6 months. Typically, we use 5-FU leucovorin, or we can do this for 3 months. I think in somewhere I said oxaliplatin not recommended, but not typically used for 6 months. It's used for less than 6 months, like 3 months. But anyway, if we choose observation, that is for stage 2, even if they have high features, the reason is because patients with MMR deficient or MSI high, they are resistant to fluorobarimetine, which is a 5-FU, and those patients is a dilemma. Actually, what do we do about them because they don't benefit from the drug and they have high risk features. So the best approach is uncertain. You may end up using oxaliplatin for those patients. So for stage 2, this is just to justify using chemotherapy for those patients at high risk. With the presence of this test being available, actually the circulating tumor DNA, if it's positive, those patients, there was a study done to show the role of adjuvant chemotherapy for stage 2, which is typically we don't use chemotherapy, but those patients being given chemotherapy, the benefit is so high, it is actually the PFS. PFS is actually 86.4% for 3 years compared to the historical series of less than 20%. There are ongoing 3 clinical trials for using circulating tumor DNA to decide on chemotherapy. This is still ongoing. Those are 3 clinical trials. COBRA, those are one of them. Those are the clinical trial ongoing to determine the role of adjuvant chemotherapy for patients with circulating tumor DNA. So for stage 3 colon cancer, for those patients, all of them, we offer them chemotherapy, of course. For stage 3 node positive, and the reason has been with multiple clinical trials and studies, it's confirmed that chemotherapy for stage 3 cancer has 30% reduction in risk of recurrence, 20 to 32% reduction in mortality. We initiate chemotherapy within 6 to 8 weeks of surgery. The chemotherapy is typically 5-FU based, FOLFOX, KBOX, which is an oral form of 5-FU instead of the IV, especially in our country in Sudan. For FOLFOX, you need a continuous infusion of 5-FU, you need a pump. So oxaliplatin oral is a good alternative, actually, instead of FOLFOX. Just you need to remember, this is something that we need to keep in mind. The PPI, all these acid reducers, they interfere with the absorption of capecitabine or Xeloda, so don't give them together, or at least 2 hours or more between the drugs. Otherwise, it interferes with the absorption of Xeloda, and the patient may not benefit from it. Just remember that. Adjuvant radiation therapy, as we said, for colon cancer is not a standard, only for invasion to fixed organ. Oxaliplatin-based chemotherapy. This is an old study. Most of people aware, and they know this study. It is the Mosaic study, which is since that this study, FOLFOX, oxaliplatin-based chemotherapy, replaced the old standard chemotherapy, which is 5-FU leucovorin. So now, with this study of more than 2,000 patients, now become the standard of care. It shows here the benefit of the disease-free survival of the oxaliplatin-based chemotherapy. So it becomes standard of care. Actually, there's an analysis of individual patients' data from more than 20,000 patients, and that's actually reassure us that is oxaliplatin-based chemotherapy for FOX is becoming the standard of care. So Xelox, KBOX, you may hear with this term interchangeably. So you can say Xelox, KBOX, the same. So if you say Xelox, that means Xeloda, KBOX means capecitabine. So Xelox or KBOX. So Xelox or KBOX significantly improve disease-free survival and recurrence-free survival compared with the 5-FU leucovorin, and with a trend to overall to superior overall survival. Xelox is similar to had a similar PFS to FOLFOX, and since then the oral chemotherapy become equivalent to the IV chemotherapy, which is requiring, as I said, a pump with infusion over 46 to 48 hours. So not practical in country like Sudan. In our country, Sudan, we have a pump, so you can take an oral chemotherapy instead of the continuous infusion of 5-FU. So Xelox, KBOX equal to FOLFOX. Adjuvant oxalibase, I think we just the same thing. So Xelox or KBOX is non-inferior to FOLFOX. Xelox or FOLFOX safety profile are balanced. Xelox offer advantage of oral chemotherapy, fluorobpyrimidine. So Xelox or KBOX is a good alternative to FOLFOX, as I said, especially in our country. So adjuvant FOLFOX, KBOX, do we give it for 3 months? Do we give it for 6 months? For how long? So there are a couple of clinical trials. IDEA clinical trial, they compare 3 versus 6 months, and this is the outcome of the study. It said high-risk patient, T4 or not N2 disease, the preference is to give them 6 months of oxaliplatin chemotherapy. For patients with low risk, T1, T3, N1, 3 months oxalibase chemotherapy is enough, and oral chemotherapy is preferable. So KBOX or Xelox. So there's another clinical trial, which is a phase 3 trial from Japan, ACHIEVE trial. They did the same thing, and they said the stage 3 colon cancer, FOLFOX, KBOX, 3 months for they compare 3 to 6 months. They said it does not compromise efficacy of the chemotherapy, particularly in patients with low risk disease. Their median follow-up was for 74 4.7 months, and they come up and they said 5-year overall survival is similar, 87 versus 86.4%. Neuropathy actually is less, of course, with 3 months. As we know, cumulative dose of oxaliplatin is less. So here we're saying that is 3 months for the low risk, 6 months for high risk stage 3 colon cancer. What about rectal cancer? The treatment for rectal cancer is totally different from colon cancer, of course, as you know. So for the rectal cancer, and then the non-metastatic, all patients across the board with rectal cancer, they should have an MRI with contrast, MRI of the pelvis, or endoscopic ultrasound. EUS or MRI is the must for all rectal cancer. If it is clinically a T1, MRI is very good to tell you about the layers of the rectum and invasion to the through the wall and the lymph node. So if the MRI or EUS, either of them, show that it's a T1 N0, then endoscopic resection, and there is a criteria for it, or more just to avoid colostomy. So you do minimal surgical procedure on if the tumor is amenable to local excision. So you could do that, and there's a criteria for that. It's a very strict criteria for that. For patients with T2 that goes through reach the muscularis, not to the serosa, not a T3, node negative, surgery is a standard of care. There is no need for chemotherapy, unless very special cases, selective. T3, T4 reach the serosa all the way down or to adjacent structures or a node positive. That's what we call locally advanced rectal cancer. And that we're going to talk about that in details. For this patient with a local advanced rectal cancer, nowadays there are so many options. And the patient is the patient to decide. Basically, we should let the patient be part of the decision, because colon cancer is not all about mortality. It's also about mortality and quality of life, because most of rectal cancer require colostomy, because especially distal rectal cancer where the sphincter cannot be preserved. So there are too many options the patient to choose from. Patient is the boss, so they have to make that decision. This is the criteria for the endoscopic resection, very detailed. But the key here for malignant polyp, the key is to remove the polyp in total, in one piece, not fragmented. If you do that, then it's good. If you end up with fragments, margin is not clear, then the dilemma that the patient get into a lot of things to be done. So endoscopists remove the polyp in one piece. If not able to, just don't do it, because once you remove it in pieces, then it's a dilemma. So criteria for local excision are right here. I'm not going to go through them. This is just the criteria for local excision. You have to fulfill all these criteria to offer the patient local excision and not to have a full surgery. Patient with the clinical T1, T2, and 0 that is not reached the serosa, the outside, that's what we call it stage 1. For those, we do surgery, either LAR, low anterior resection, or APR, abdominal perineal resection, and there is no need for adjuvant therapy, no radiation, no chemotherapy, except very few selected cases. But in general, no. But you may consider giving new adjuvant chemoradiation actually for the patient. Those are the one that is, they want to preserve the sphincter, because the surgery with the APR, the sphincter is gone. They have to have a colostomy, which is quality of life. Patient, they don't want to do that. So if patient doesn't want to do that, then, as I said, let the patient make the decision. So to preserve the sphincter, you may give adjuvant chemotherapy. However, it's controversial, but it's a patient option. For patient with poor surgical, patient considered poor surgical candidate, or patient who refuse APR, say, I don't want to get colostomy. There are patients like that. They're just stubborn. They don't want to do it. Then you may give them adjuvant chemotherapy, reevaluate the MRI, AUS, and do an LAR. So there are a lot of options, because colostomy, of course, is not fun. Patient still refuse surgery or poor candidate, complete clinical or have a complete clinical response to adjuvant chemo or to the chemoradiation, then it's fine. You don't have to do surgery. You may do full thickness local excision, and close follow-up indefinitely. This is the cases with a lot of options, what we call locally advanced rectal cancer. So there are so many options the patient to choose from nowadays. Especially, the reason I say that because there are a lot of patients, even in my practice, there are patients that are especially young. Remember, we said nowadays there are increase in the left-sided colon cancer, including rectal cancer in young patients. So young patients, they don't like to have colostomy. They may sometimes, some of them, they may say, even if I have to die from this, I don't want to have a colostomy. I have patients said that. So it is the patient choice. So there's a lot of options to choose from. Fortunately, nowadays there are options. So rectal cancer, neoadjuvant chemotherapy. So what are the role of neoadjuvant adjuvant therapy? It could be chemotherapy, it could be immunotherapy, it could be radiation, it could be both. So this is a German study, seminal German rectal cancer study. They assess neoadjuvant versus adjuvant chemoradiation. Neoadjuvant or preoperative chemoradiation is they're finding, they're saying that it provides a superior sphincter preservation rate, lower rate of anastomotic stenosis as a long-term complication of pelvic RT. If you give it after surgery, it has a better local control while providing similar long-term survival. So for the neoadjuvant therapy. So chemoradiation is preferred given preoperatively or neoadjuvant rather than give it after. So give it before surgery, even for a T3, before surgery, that's the best. Even for a T3, T4, of course, not positive, it is a must. So, or for tumor which is in the distal rectum, trying to preserve the sphincter, you give it before surgery. So you can convert the APR into sphincter preserving LAR, low anterior resection, so you don't have to mess with the sphincter. Possible invasion of mesorectum or threatened circumferential resection margin, the CRM, then also it is preferable to give, in general, it is to give neoadjuvant therapy rather than adjuvant. So it becomes a standard of care that is neoadjuvant or preoperative chemoradiation, the standard of care for stage 2 and 3 rectal cancer. So rectal cancer neoadjuvant therapy, again, yeah. So the preoperative chemoradiation is typically fluorobpyrimidine chemoradiation. If you use it with radiation, it is only 5-FU or capecitabine oral during radiation for 5.5 to 6 weeks, followed by surgery, and usually wait for 7 to 10 weeks. So don't do the surgery immediately, don't do it too late. So the standard is 7 to 10 weeks after completion of the concurrent chemotherapy, take the patient for surgery. So you give at least 4 months post-operative adjuvant chemotherapy for FOX or Zelox. And remember, it is regardless of the pathologic findings. So for patients who receive concurrent chemoradiation, they have surgery, and they have a complete pathologic response, still offer them FOLFOX or Zelox or Kbox, regardless of the pathologic finding, even if they achieve complete pathologic response. That's the key. So, or another option is you give what is called TNT, total neoadjuvant therapy. So basically, instead of sandwich, you give the chemoradiation, surgery, chemotherapy. So surgery in the middle. Here you do everything before surgery, what you call total neoadjuvant therapy. That means you give induction chemotherapy for FOX for 4 months. Not more than 4 months, 4 months or less. 4 months is the standard. Then follow that with a long course of chemoradiation. Or you could do the opposite. You can give the long course chemoradiation. You give radiation with the capecitabine or 5-FU continuous infusion during radiation, and then follow with the induction chemotherapy. And so you finish everything and you do the surgery later, and still wait for 7 to 10 weeks to do your surgery. Am I going too fast? Hello? People, are you there? I hope I'm not the only one in the meeting. Okay. So for locally advanced rectal cancer, we give, so the question, do we give chemo and radiation together? Or I just want to check to see that is it. Are you guys there? Okay, I'll continue. So there is a study to decide, do we need radiation plus chemotherapy or can we omit the radiation? There is a study called Prospect Phase 3 trial. In this trial, locally advanced rectal cancer who are candidate for sphincter sparing, T2, and positive, not positive. For this patient, they gave chemotherapy, FOLFOX for 6 cycles, surgery, LAR, APR, followed by FOLFOX for 6 cycles. Basically, chemo, surgery in the middle, a sandwich. If the patient does not have a good response to chemotherapy, that means the tumor did not decrease by more than 20% or more, they give them radiation. So for patients who are responding, they give them chemo, surgery, chemo. Basically, the whole idea is they try to omit radiation, especially for women, when you give radiation to the pelvis, ovaries, infertility issues. So versus giving concurrent chemo radiation, which is the standard of care. So you give concurrent chemotherapy, surgery, followed by adjuvant FOLFOX for 8 cycles. And they said the new adjuvant chemotherapy, the non-radiation regimen, which is the experimental arm, is not inferior to the new adjuvant CRT concurrent chemo radiation. The disease-free survival is very comparable, 80 to 78 versus 78%. Overall survival and local recurrence are very similar. So this option is reasonable for young patients. This approach provides option to preserve fertility and avoid early menopause. This is for women. So there is a study for short course of, instead of omitting radiation altogether, there is a study for a short course of radiation. I'm not a radiation oncologist, you know better. So for people who have training of radiation, this is study Rabidu Phase 3 trial. It's a short course of radiation versus long course of radiation, which is standard care. This is for local advanced rectal cancer. They give a short course of radiation for 5 days sessions over 8 days, followed by Capox, which is oral chemotherapy for 6 cycles, or FOLFOX for 9 cycles, followed by TME, which is the surgery for the rectal cancer, versus the long course radiation and the Xeloda or capecitabine, followed by the surgery, the TME, followed by adjuvant Capox for 8 cycles, or FOLFOX for 12 cycles. It's optional, actually. And their conclusion is they said the experimental arm, which is a short course of radiation for 5 days only, for 5 grays only, for 8 days actually. Yeah, the experimental arm versus standard arm, they did a follow-up for 4.6 years, and they come up with they said cumulative probability of disease-related treatment failure is 23.7 versus 30.4. It's not that bad, so it's an option, but it's one study. In the United States, we do not actually, or very rarely, give the short course radiation. It's still the standard of care is the long course radiation. Non-operative management of colorectal can we treat with no surgery? So basically, no surgery, non-surgical treatment. Is it an option? So it is a phase 2 clinical trial for more than 300 patients with local advanced rectal cancer. They gave them TNT, total neoadjuvant therapy. So for patients who receive concurrent chemotherapy with the total, you give the chemotherapy, the radiation, everything, like what we call total neoadjuvant therapy. And for patients who achieve complete response to the neoadjuvant therapy, So we offer them surveillance only, no surgery. For patients who had an incomplete response, so we do a colonoscopy with a biopsy, we do a CT scan, we do an MRI, and there is no complete response. So those patients, we have to offer them chemo. But this study mainly focused for patients who achieve a complete pathologic response. Repeat biopsy negative, MRI looks good, CT scan looks good, no disease, so offer them surveillance only, no surgery. So they did the follow-up for this more than 300 patients, and here's the conclusion. So it said patients on surveillance who underwent surgery after tumor regrowth had similar 5-year PFS as those who had immediate TME. It is 64% for each group. So it's a choice. As I said, patients with rectal cancer, they have the choice to do either. I mean, they have to be part of the decision because this is about their life, quality of life. So patient with locally advanced rectal cancer treated with neoadjuvant chemotherapy, especially TNT, total neoadjuvant therapy, surveillance at a center of excellence for rectal cancer is considered an appropriate alternative to surgery. I have actually a couple of patients, young patients, they decide not to have surgery, not to have colostomy, and I now just follow them very closely. So treatment for stage 2 and 3 rectal cancer without surgery or RT or chemo. Wow, this is here now. We're talking about not only omitting surgery, we're omitting radiation and omitting chemotherapy. This is very interesting. So no chemo, no radiation, no surgery. So what do we do? So this is a very small clinical trial. It is a phase 2 trial. It presented during ASCO, and it was in the NCCN, in the news. This is a patient with cancer, stage 2, stage 3. They have the deficient MMR. Remember the MMR and MSI high. Those are patients. It was only 12 patients who are brave enough to say, we will do it. They decided not to have surgery, not to have radiation, not to have chemotherapy. So we give them what? We give them PD-L1 inhibitor. Immune therapy. It's not a chemotherapy. There's not no radiation, no chemo, no surgery. There is PD-L1 inhibitor, dostarlimab, which is Gemberli, and all 12 patients they have complete response. Complete. They receive and they achieve clinical complete remission, 100%, with no evidence of residual tumor, gone. No patient required chemotherapy, radiation, or surgery, and no recurrence during the follow-up so far, as far as I know. However, it is not a standard of care. It's a very small group, but it is an option. So just remember, patient with the deficient MMR or MSI high is not too. There are not too many. Only 5 to 10% of rectal cancer are deficient MMR. And anyway, remember we said they are resistant to chemotherapy, the 5-FU the load. So who we may offer this unique type of treatment, no radiation, no chemotherapy, no surgery. Again, remember, this is not a standard of care yet. However, it's a patient choice. It may be an option for patients who have the following. Patient who place a high value on avoiding the long-term morbidity associated with surgery and radiation. Patients who are willing to accept the uncertainty of long-term outcomes. Patients who are, accepting the small risk of fatal adverse effects from immunotherapy. You know, the immunotherapy causes pneumonitis, colitis, it could be life-threatening. Patients who commit to very close follow-up. We do every 4 months pelvic MRI, rectal exam, digital rectal exam, sigmoidoscopy with biopsy. So if patient fulfill those criteria, we can offer this immune therapy, no surgery, no radiation, no chemotherapy. So short course radiation versus long course radiation, or long course concurrent chemo radiation. As I said, I'm not a radiation oncologist, but I'm on the chemotherapy side. But there are some studies looking into the short radiation. The long course chemo radiation is typically given for patients with bulky disease, not positive T4. if circumferential resection margin, CRM, or complete resection status are predicted to be at risk. So those we offer them, we don't play with that. We offer them long course. We don't offer them short course. However, the short course of radiation or short course radiation followed by chemotherapy may be an option for one of the following. It's not standard of care in the United States here, actually is not a standard of care yet. We give the long course. I know in Europe, there is more interest in doing the short course, but it could be offered to patients with the T3 NN with clear CRM, EUS or MRI, showing that the CRM is free. Patients with T1, T2, N1, N2, so at a little bit lower risk for cancer recurrence, medically not candidate for long course CRT, metastatic disease to minimize delay of systemic therapy, or patient with synchronous potentially resectable liver metastasis. So we don't want to give a long course without giving systemic therapy, so you can offer a short course, so you can go for resection of the liver metastasis. We'll go over that a little bit later. So there are two randomized trials demonstrated short course RT associated with long-term outcome comparable to long course chemoradiation. As I said, these studies are European studies. In the States, it's not a standard of care yet. So for stage 2, stage 3 cancer, who received no new adjuvant chemotherapy. They saw the surgeon, they have the surgery, and then come to you, which is not a standard. So any patient with stage 2 and 3, they should not have surgery before receiving some kind of new adjuvant therapy. Standard is concurrent chemoradiation. So, but anyway, if it happens, what do you do? So adjuvant chemoradiation, even if TME performed, still we offer them adjuvant chemotherapy. That's not standard of care, but if it happens, here is the best practice. Give them 2 months of chemotherapy, especially for FOX or KBOX. Give them 6 weeks of chemoradiation. Give them 2 months for the same chemotherapy. So basically, sandwich of concurrent chemotherapy, chemo at the beginning, chemo at the end. Or you can give them chemo for 4 months, followed by chemoradiation. Either one is fine. For patients with margin negative, for patients who have the margin negative T3 and 0, patients wish to avoid potential toxicity of post-op radiation. Those patients may offer them the 12-gene recurrence score, Oncotype DX, or circulating tumor DNA testing if available for minimum residual disease, and the tests are available. The test called Signatera detect circulating ctDNA or Gordon Reveal. Those tests are available. You can do them for those kind of patients. It is helpful. So for what about? So this is for the patient who received treatment, and now we're talking about patients who are unfortunate and develop a recurrence. So recurrent colon cancer is really, the treatment is kind of not easy. So the best treatment, of course, for surgery is to cut it out. So complete radical resection is a prerequisite for cure. If you want to cure them, radical surgery. But radical surgery is horrific. It is pelvic exentration. You remove everything. You empty the pelvis. So after that, if the patient not receive radiation, you just follow the guideline for pre-op therapy. The patient receive no previous chemotherapy or offer them chemotherapy. However, the benefit of adjuvant chemotherapy in those cases is not well established yet. Here are the contraindications for radical surgery, big list. You can just read them. Here the conclusion for non-metastatic radical cancer. Remember I said the options are many, but here the conclusion. For stage 1, surgery only. For stage 2 and 3 rectal cancer, new adjuvant concurrent chemoradiation is the standard of care. Up to date, recommend for most local advanced rectal cancer, long course radiation is suggested or preferred rather than the short course radiation. Now, we move to metastatic disease. I'm sorry, it's taking too long, but it's a long course. It's a long subject, but we'll try to cover it. So metastatic disease. So what about metastatic disease? Mode of metastasis, hematogenous through the blood, usually to the liver, lung, bone, and others. But liver is the target for colorectal cancer. Distal rectal cancer may metastasize to the lung before the liver, and that's through the inferior rectal vein, which drains into the IVC rather than the portal vein. Metastatic disease, colorectal cancer, 50 to 60% colorectal cancer patients will develop metastasis during their journey. And the metastasis is typically synchronous, the metachronous, but the synchronous is 15 to 20% at the time of diagnosis. And if it happens, 80 to 90% unresectable. Remember, metastatic colorectal cancer with intact tumor and synchronous metastasis do not do surgery for the colon. Don't let the surgeon take them to surgery. Tell them no, it is not. I'll show you the study. But the only time we do colectomy or hemicolectomy for metastatic colon cancer only and only if in case of acute obstruction and significant bleeding, basically emergency. Then fine. If they're not obstructed, completely obstructed, even as long as they move bowels, as long as they move some bowels, doesn't have to be normal, but move some bowels, as long as not hemorrhage, not just bloody stool, just talking about hemorrhage, then you do surgery, otherwise no surgery. Metachronous metastasis is the most common and it's mainly to the liver. Here's the study for the hemicolectomy for stage 4 cancer metastatic disease. There was a study. It was a phase 3 Cairo 4 trial. Basically, they said for primary tumor resection followed by chemotherapy, so metastatic disease, taking to surgery, and then give them chemotherapy. That's not the best. That's not standard of care. They said it has a higher 60-day mortality than systemic chemotherapy alone. So it is kind of harmful. So unless you have, as you said, complete obstruction or hemorrhage, not just a bloody stool. Factors associated with higher risk are elevated LDH, AST, ALT, and ANC neutrophilia. Liver metastasis, going to cover this liver metastasis. In this part, we're going to cover the liver metastasis. More than 50% of patients died of colorectal cancer have liver metastasis at autopsy. Liver mets is a cause of death in the majority of patients with colorectal cancer. In 30% liver, in 30% of the cases, liver is the only site of disease, and that's our interest. So we are focusing this patient, or the 30% who has liver-only disease. So without surgery, the 5-year survival is very low for patients with liver metastasis. In selected patients, resection of liver metastasis could lead to cure. The 5-year survival, about 50%. Very interesting. So treatment of liver metastasis. So what do we do? Resection of liver metastasis. So liver resection currently represents the only potentially curative therapeutic option for hepatic colorectal cancer metastasis. The 5-year survival rates of 25% up to 58% have been reported. So patient with liver metastasis, it is not a death sentence. Could be actually, on the other hand, could be a curative disease if we handle it correctly. So colon cancer potentially with potentially resectable liver metastasis are those patients with 4 or less liver lesions, metastatic lesions. We do partial resection in selected cases. The 5-year relapse-free survival rate is 30% and 5-year survival up to 58%. As we said, patients with more than 4 liver lesions or bilobar disease or portal lymph nodes, we offer them new adjuvant chemotherapy followed by surgical evaluation. If they become trial, the option of chemotherapy, either bevacizumab, FOLFOX, or So they may achieve an R0 resection rate 22% versus 6%. Yeah. Patient with the RAS or BRAF wild type, we offer them anti-EGFR. We'll go over that later. Oh, this is a question here. Actually, this is an area of controversial area. So patient who had a liver resection with R0, if you resect the liver and the margin is negative for metastatic disease, do we give them chemotherapy or not after? Actually, there are different opinions. So some people say, no, if you're done with it, just observe them, don't subject them for more chemotherapy. Some people give them adjuvant chemotherapy, like a non-metastatic resected, removed, give them chemotherapy. So it's kind of controversial for patients with the R0 resection from the liver. Rectal cancer, potential resectable liver metastasis. One of the following strategy is acceptable. You have a rectal cancer patients, liver metastasis. So here are the options. You can give them initial chemotherapy, short course radiation, or long course radiation chemo, and follow with the resection, synchronous or staged, one after the other. Or you give them initial chemo radiation or short course radiation followed by chemo followed by resection. All of these are fine. All these are case by case. Up to date suggests short course RT rather than long course. Remember, up to date suggests long course radiation for locally advanced rectal cancer. But for patients who have metastatic disease, because you don't want to give them radiation 6 weeks or so, and then they may have disease progression. So prefer to give them short course radiation rather than long course radiation in this case. The contribution of pelvic RT to outcomes, especially local control and survival, is unclear. So selective internal radiation therapy, radioembolization, which we use the Y90 microspheres. This is an area of interest in special centers. So liver transplant for metastatic colon cancer is in clinical trial now. So TransMet trial is undergoing for patients with liver metastasis from colorectal cancer. They offer them a clinical trial. It's ongoing, so it's not standard of care. Now we go to a different subject now, which is the systemic chemotherapy. I hope you are all awake and follow me. I don't hear from anyone. I assume that people still following. I haven't checked, but I will keep going. It's a long subject. Systemic therapy. So now, new drugs led to improvement of disease-free survival and overall survival. So 5FU, which was the standard of care years ago, it leads to 5 to 12 overall survival. However, with the new drug, oxaliplatin, irinotecan-based chemotherapy, the overall survival is up to 3 years. And addition of biologic agents, the 5-year survival is 20% has been reported. And even better than that now with the immune therapy, and we'll go over that. Cytotoxic drugs, Folfox or Kbox or Zelox, in just whatever name you like, you can call it, is an alternative to Folfox. We talked about it previously. Folfiri, which is irinotecan with the 5FU, but remember, it used to be a regimen called Capiri or Zeliri, where you use irinotecan and capecitabine or Zeloda, but now it is recommended not to use this regimen. Do not use Capiri or Zeliri, and because of overlapping toxicity, because irinotecan causes diarrhea, and 5FU or Zeloda causes diarrhea. So capecitabine causes diarrhea, irinotecan causes diarrhea. So overlapping toxicity. Do not use Capiri anymore, Zeliri anymore. If you want to use capecitabine, use it with the Folfox, with the oxaliplatin for Kbox. If you want to use irinotecan, use it with 5FU. FOLFIRINOX. FOLFIRINOX is a rough regimen. If you have a young patient in a good shape, not a lot of comorbidities, this is a very effective regimen. 5-fluorouracil still an option. Zolot is an option. Lonsurf is an oral chemotherapy is an option. The S1 is not in the state. I have never used it. I think it's more in the Far East. So fluoropyrimidine toxicities. This is just a reminder with this toxicity of these drugs is they've seen benign chemotherapy or mild chemotherapy, if you will, but it has toxicities. So remember, patients with receive 5-fluorouracil, they may develop diarrhea, mucositis, neutropenia, and that's basically because of these two enzymes, the DPD, dihydropyrimidine dehydrogenase deficiency, or thymidylate synthetase mutation. Those is associated with reduced TS production and subsequent 5-fluoro toxicity. So just remember that. Irinotecan toxicity, couple of them. Remember, the reason I mentioned this because this is a backbone drug for the colorectal cancer. We use all of them. Whatever we use, we go back we'll go back again and again for the same drugs. So diarrhea, it is due to accumulation of active metabolite, the SN38 in the intestine lead to diarrhea. The SN38 metabolized by the enzyme UGT1A1, and so you may need to check for the gene mutation because mutated patients, especially homozygous mutation, they develop toxicity from irinotecan. And remember, irinotecan associated with hepatic steatosis, steatohepatitis, and hepatic vascular damage. The reason I mentioned that, especially if we give the chemotherapy pre-operatively for patients with potential liver resection or hepatectomy. So just give least amount of chemotherapy to avoid hepatic steatosis. Oxaliplatin toxicity, neurotoxicity, peripheral neuropathy is the commonest, which is usually if patient exposed to cold, any kind of cold drink, cold weather, whatever, cold. Very rare, actually, I have 2 patients with posterior reversible encephalopathy syndrome, PRES. And it has shown that supplementing calcium and magnesium may protect against neurotoxicity. You may try it. Give them calcium and magnesium. We used to give it for the adjuvant, and then we stopped doing it because there was some paper suggesting that it reduced efficacy of the oxaliplatin if you give calcium and magnesium. But in patients with metastatic disease, have neurotoxicity, using them is reasonable. Oxaliplatin, remember I said irinotecan causes steatosis. On the other hand, oxaliplatin causes sinusoidal injury, which may lead to portal hypertension and splenomegaly. It is dose dependent. By the way, concomitant use of bevacizumab, Avastin may protect against the development of hepatic sinusoidal injury. Let's remember that. Biologic agents, there are many of them right nowadays. Anti-EGFR. These are typically, there are 2 drugs now, which is cetuximab and panitumumab, Erbitux and Vectibix. It is typical for patients with KRAS, BRAF wild type, no mutation. So for patients with the BRAF mutation, BRAF V600E mutation, drugs for or anti-BRAF or BRAF inhibitor, Braftovi or encorafenib are oral chemotherapy, very effective for those patients. For patients with the KRAS G12C, the G12C KRAS mutation. Now there are 2 drugs could be used, both of them oral, anti-VEGF inhibitor, bevacizumab, Avastin, and PD-L1 inhibitor or immunotherapy, especially for patients with, not especially actually, this is standard of care now, for patients with the MSI high or deficient MMR, we use immunotherapy without chemotherapy. That's the first line now, become a standard of care. Patient with the DMMR, deficient MMR, MSI high. HER2 positive colorectal cancer, we use trastuzumab. There are different anti-HER2 drugs. There's a new drug, which is a multi-tyrosine kinase inhibitor, now available. Actually, the small molecule kinase inhibitor now available. There are two, this is oral drugs. So these are targeted agents. So metastatic MSI high and deficient MMR, the role of immunotherapy. The clinical trial, Keynote 177 clinical trial demonstrate they use pembrolizumab, which is a Keytruda versus chemotherapy, and they found pembro lead to statistically significant improvement in PFS, progression-free survival, 65.5 versus 8.2 months. That's significant, and there is no statistical significant difference between in the overall survival. But however, the median, the follow-up is still ongoing. So the median in months is 49 months versus 27 months. So it's still ongoing. Checkmate, which is a study for Opdivo, which is nivolumab and Yervoy epi. This is a multi-center non-randomized clinical trial, and it showed that Opdivo had better, actually have the duration of response more than 12 months. But if you give both Opdivo and Yervoy, nivolumab and ipilimumab, the duration of response is more than 12 months also. So for metastatic disease with MSI high or deficient MMR, immunotherapy is considered standard of care. So if you see a patient with MSI high, deficient MMR, your first choice is the non-chemotherapy option, which is immune therapy. It is now standard of care. So for HER2 positive colorectal cancer, this is a multi-center Montana trial that showed that using two drugs targeting the HER2, one of them is oral, tucatinib, which is Takisa, and trastuzumab Herceptin, for patients with RAS wild type, HER2 positive, and they're chemorefractory, so they have to have chemotherapy. The overall survival, and the response is 38%, median duration of response 12.4%, 2.4 months. This is a new drug, which is an oral drug, which is a small molecule kinase inhibitor. Let's go over it here. There is another oral drug, which is a RAS G12C mutated patient. This is the Crystal 1 study. This drug now is approved, is in use. One of them, this is another in a clinical trial, but not approved yet. So here this is just a summary for the colorectal cancer treatment landscape. This is for metastasis. This is the landscape. So just follow that. So first line, if you have a patient, this is the first line. This is upfront systemic therapy. Patient with the MSI high, deficient MMR, your option is immunotherapy, which is Yervoy, nivolumab and Yervoy or epi, or pembro or Keytruda. So this is your first line. If you have a patient with RAS, KRAS, and RAS mutation, so your chemotherapy option is a doublet or triplet therapy with anti-VEGF, which is bevacizumab. KRAS regardless, and BRAF, actually RAS usually is wild type if the BRAF is mutated. So BRAF V60E wild type. Oh, this is a KRAS BRAF wild type. Sorry, this is a KRAS NRAS BRAF wild type negative. Oh, no mutation, and HER2 negative. So for the left-sided colon cancer, you know that nowadays we divide colon cancer to left-sided or right-sided. For the left-sided colon cancer, a doublet, which is like FOLFOX or FOLFIRI plus anti-EGFR, cetuximab or blinatumomab. Right-sided doublet triplet, which is FOLFOX triplet plus anti-VEGF and VEGF. Here, the one that's what I meant. The one with the BRAF mutated, the treatment is doublet or triplet plus anti-VEGF if the first line. HER2 positive, doublet or triplet therapy, anti-VEGF. For the second line, if the RAS is mutated, KRAS or NRAS mutation, use a doublet FOLFOX FOLFIRI plus anti-VEGF. It should be RAS, should be a K there. KRAS, BRAF, wild type, HER2 negative, doublet plus VEGF. Here, the second line. In the second line, if you have a BRAF mutation, then no chemotherapy. Use Braftovi, which is encrofenib, and cetuximab, which is anti-EGFR. If they're HER2 positive, same chemotherapy, doublet, anti-VEGF, like bevacizumab. For the third line, if the RAS is mutated, here are your options. If the RAS is wild type, here's your option. If the BRAF mutated, the option here, what I'm coming to this here, actually, that's what I meant. The HER2 positive third line therapy is in HER2, it's the drug of choice, but you can use trastuzumab, pertuzumab, or lapatinib. Fourth line, this is your fourth line options. So this is just basically give you a landscape for the sequence of using drugs through. So you can see patients with colorectal cancer, they can live long, moving from first line, second line, third line, fourth line. They can keep going. Peritoneal carcinomatosis, isolated peritoneal disease, that means in less than 12 peritoneal quadrants and few areas less than 5 centimeters may be rendered cancer-free. How? By doing surgical cytoreduction with HEPIC. Heated intraperitoneal chemotherapy. And this is a study showing that is a complete surgical cytoreduction with HEPIC may lead to median survival of up to 5 years. Surveillance, yeah, we need to work up a little bit. So surveillance for colorectal cancer. So all colorectal cancer patients, they need a repeat colonoscopy after surgery in 1 year. So 1 year colonoscopy is a must. If colonoscopy was not complete or not done, you do a colonoscopy in 3 to 6 months after the patient being initiated on treatment and stabilized. No advanced adenomas, repeat colonoscopy in 3 years, and then every 5 years. For advanced adenomas, present if advanced adenoma present, repeat colonoscopy in a year. This is for surveillance. For stage 2, on stage 4, you do lab, CBC, CMP, liver function, blood counts, CAA every 3 to 6 months for 2 to 3 years, then every 6 months for 3 to 2 years, CT scan every 6 to 12 months for 5 years. And now we add to the surveillance molecular residual disease, MRD, by doing we check circulating tumor DNA by a test called Signatera or Guardant Reveal. And here is the reason we do this molecular residual disease, MRD, for checking for circulating tumor DNA for monitoring. If positive, it shows that it is a prognostic for inferior DFS. It's predictive of benefit from adjuvant chemotherapy. Circulating tumor DNA positive patient followed with observation only, more likely to have recurrence. So this test adding a good tool to the surveillance by doing ctDNA for negative ctDNA patients. So the question, do they benefit from chemotherapy? Well, that's a big question. We don't know yet. So circulating tumor DNA or molecular residual disease, MRD, is now considered a powerful prognostic and predictive tool in stage 2 and 3 colorectal cancer. For stage 2 with positive cDNA, this is a study. They found out as patients with stage 2 who have a positive ctDNA, the adjuvant chemotherapy actually helped them. 84% PFS versus less than 12% in historical series. And here the clinical trial, I think we have this slide before. So these are the tests. Signatera test, you do the follow-up, may start before surgery, and then you can, this is just a program, you do it 1 month, 2 months, 4 months after surgery, then every 3 months for 2 years, then every 6 months for 3 years. I think there are 2 missing here. Then another test is Gordon Reveal for ctDNA. This is a program, something very similar. This is the 5-year survival for colorectal cancer. Here's the list. And for the rectal cancer, here's the list. We're almost there. This is anal cancer. Just few words about anal cancer. Anal cancer either could be keratinizing squamous cell carcinoma or rise in transitional line or squamous mucosa, then keratinizing, basaloid. So for patients with rectal cancer that is read as a squamous cell carcinoma, we treat them as anal cancer, not as rectal cancer. So the treatment, non-metastatic, no surgery. No surgery, as you know, for anal cancer. We treat with the concurrent chemoradiation using 5-FU or mitomycin for complete clinical response, and it leads to complete clinical response in 6 to 12 weeks. Actually, it could be, it may take up to 26 weeks to achieve a complete clinical response. For recurrent disease, we do APR surgery. For metastatic disease, we use cisplatin 5-FU, carbotaxol is reasonable. Second line is immunotherapy, pembro or nivolumab. We are done. So here are the 3 slides for to take home messages. Slide number 1, to be aware of colorectal cancer symptoms. Not all hematochezia, rectal pain, tenesmus are due to hemorrhoids or dysentery. So those patients should be checked with scopes. And not all irregular bowels are due to IBS. Colorectal cancer could be cured if detected early by screening colonoscopy. Average patients at age of 45 should have their first colonoscopy, then every 10 years if normal. High-risk patients as early as teenager get more frequent colonoscopies. Pelvic MRI and rectal endoscopic ultrasound and MMR, MSI should be done for all non-metastatic rectal cancer. Slide number 2, or before the end, 1 slide before the end, to take home message. Not all metastatic colorectal cancer is a death sentence. With new diagnostic and therapeutic procedures and effective drugs, including biologic agents, many patients may enjoy years of survival compared to the historical survival of a year or less. Few patients could be cured nowadays. So check all metastatic colorectal cancer for biomarkers. All of them should be checked for MSI if it's high, or MMR if it's deficient. Treat them with immune therapy, not chemotherapy. Use the checkpoint inhibitors. All patients should be checked for KRAS, BRAF, if wild type. Treat them with EGFR inhibitors. If BRAF mutated, treat them with non-chemotherapy, incrofenib or Braftovi and EGFR inhibitors. For HER2 positive patients in 3rd or 4th line, treat them with HER2 drugs. And this is the last slide. And thank you much. And thank you for staying for almost 1 hour and a half. Thank you. Any question or comment? I think I have charge. Want to say something? Does stereotactic liver radiotherapy have a role in metastatic? Yes, it does. So ablation for metastatic lesion is an option. Surgery is the best if you can resect. But yes, you're right. Radiofrequency ablation is an option instead of surgical resection. But surgical resection, at least you're gonna assess the margin. But it is an option. Yes. Okay. So I think we are done. If no question, we're gonna stop the recording and end the session.